Thank you very much for having me. Usually I'm the token person that annoys everyone by saying in Scotland, so today I might be that person that says in the UK. So some of this might be quite UK-centric, as Laura had mentioned, but I'm hoping it will relate to wherever you are in the world. So I think so these are my disclosures, sorry. So I'm going to talk today about the changing role of the pharmacist. There's lots of changes happening in pharmacy over the next kind of couple of years. So in the UK, for example, all pharmacists from 2025 will qualify as prescribers. So it's not a separate qualification anymore, will automatically qualify as prescribers. So I think that's important in the context of HIV as we look at what being a pharmacist means going forward. So we have often a great team of pharmacy technicians that work with us. So how can we move our roles forward where we're working to the kind of highest end of our licences to support people living with HIV? And I think that's really important, looking at the kind of last 10 or 15 years journey in HIV, where predominantly 70 or 80 or 90% of excuse me, of our patients had multiple drug interactions, and it was a big part of our role. But now, as we're moving into a new era, I think it's important to look at what the skill set of a pharmacist can do in 2023 and beyond. So can we make changes to HIV care within an MDT setting? Yes, we can. Can we independently manage caseloads of patients as perhaps consultant pharmacists? Yes, that's already happening. Can we think about the future-proofing treatment choices for specific groups of patients? So are we looking at perhaps subspecialities within HIV where we can use our skill sets? Perhaps that's a role. Multimorbidity is going to be key, and I know that there's talks later on about ageing, but some of what I'm going to talk about today is within that context, because I think it's really important to understand the role of pharmacists as being experts in medicine. So there's lots of blurring of all our roles, and I think that's one of the strengths of an MDT, is that we can all help with each other, and there's certain parts of care that different healthcare professionals are more expert with. And I think it's important to kind of go back to our fundamentals, which is managing medication and being that kind of expert in the care there. So Laura mentioned earlier about responsibility of all conditions, and I'm going to speak today about why I think that's really important. So that's not an easy fix, and that's not something that we do or we can do easily. But I think as we go ahead, and we have links with primary care, which we don't have just now, there's no prescribing, but when we're looking at comorbidities and polypharmacy, whose role is that? And I think that's a really important question that we ask in people living with HIV that are perhaps over 50 or over 60 on multiple co-medications, is who does look at that? And I think if we're honest and we think that that's the job of primary care, or that's the job of secondary care, that because that patient is under cardiology, or that they're under other areas, who does actually look at that? And I think if we look at primary care, for an example, in people living with HIV, do they see antiretrovirals on a big polypharmacy list and think that's not who I'm going to look at in managing that list, that patient's already under HIV services? But are we doing it? Maybe we are, maybe we're not. But I think it's who is that person? And I'm going to hopefully take us through a case that will look at why this is really important. So titration or under prescribing of agents, we see all the time. One of the most important things when looking at a list of medications is matching it up with conditions. And that just seems like such a no-brainer and a simple thing. But if you have somebody in front of you in clinic that has HIV but has 5 or 6 other comorbidities, but maybe are on 15 or 20 other medications, can you match it up? I guarantee 95% of the time that will not be a simple job. And it's not just a case of they're on this medication, let's contact their rheumatologist or their cardiologist. Often medications were started 2, 5, 10 years ago, and nobody's a clue where they originated on. And it's about let's make sure people living with HIV, you know, we're talking about that, the 90-90-90, and I'll kind of finish off with that. But how can we make sure our patients reach 90? Whose job is it to make sure that whilst the HIV maintains medication control as well, that everything else is as well? So providing care for poor attenders, how good are we at linking in with that? We know, and Laura mentioned it again, that people living with HIV, they see their HIV physician as their primary carer. They might not attend other areas well, they might not see their primary care physician well, because they might think, right or wrong, that we will pick up other things. And we might do that. We might, you know, certainly in Glasgow for our liver patients, we quite often add on cirrhosis monitoring because we know they don't attend gastro service as well. We'll do a 6-monthly ultrasound, we'll add an AFP, because when we did an audit of this, they weren't attending. So what else can we look at to make sure perhaps we're helping to avoid additional hospital visits if we can, and making that care pathway more simple? And what can we manage? What is within our skill set to titrate up and titrate down or stop? And I think that's something that we have to look at, you know, looking into the future for the next 5 or 10 years. Do we need to learn more out with our speciality as pharmacists to make sure people living with HIV that we look at after as HIV specialists have that longevity that is so important with regards to their medications? So what about, I mentioned previously, rationalisation of non-HIV co-meds, and I'm going to take us through a case, but a couple of the things that we see often is short courses that are never stopped, so things like apixaban, managing titration of things like SSRIs and antihypertensives. We don't need to be starting these agents or even stopping them, but it can be quite easy to make sure if there's been a plan, and if there's ever been a plan in place that these are titrated up or down, that it's happened. You know, just looking back, PPIs, I looked at this as part of my role in hepatology with hepatitis C, where there was a drug interaction with some DAAs and PPIs, so omeprazole and some different agents that we use to treat hepatitis C a few years ago, and we stopped the PPIs to manage this drug interaction. And we had a look back at, after that 12 weeks of treatment, who restarted it or who needed to restart it, and about 80% of people didn't need to restart the agent because they didn't need it in the first place. So does that fall in the role of the pharmacist? Maybe. So understanding multimorbidity, that there's nothing new here. So it's the global population of over 60s has almost doubled, but we do need to consider multimorbidity at all ages. So I do a teenage clinic, young adults, and some of our people living with HIV in younger ages can often be on many medications as well. So often the antiretrovirals is the easiest part of care, and I'm going to talk about what that means for an HIV pharmacist today. So an ageing HIV population, there's lots of data now that shows us kind of into the future as we progress, the age of people living with HIV significantly increases. Is there a difference in people living with HIV? Well, yes, there is, and that's another reason I suppose I'm harping on about this today. If there are more multimorbidities, more complexities of polypharmacy, more higher risk in people living with HIV, then that's more of a reason that it needs to be on our radar, that it's been done properly. Drug interactions and adverse outcomes. This is probably the least amount of DDI slides I've used ever in a talk, so I was glad Laura put up the Liverpool table because I don't think I've got it in today. But again, there'll be no surprise here. There's lots of studies that show people living with HIV and looking at hospitalisations, and I think this study was in France, that there was a 20% versus 10% risk in hospitalisation if you were on a contraindicated co-medicine. So nothing that, as we move forward, that drug interaction is still so pertinent. And what I'm saying today is perhaps 70 or 80% of our people with HIV that we were looking after 10, 15 years ago were on darunavir, ritonavir, they were on boosters, they were on cobicistat, and we don't have that now, but it's still so important, it still can't be overlooked. So these are the top 20 co-medicines that have been searched for in the Liverpool websites over the last year, and you'll see there's no surprises there. Lots of things that are very prevalent in multimorbidity, cardiac disease, and an ageing population. So I'm going to take us through Gladys at different stages of her life. Gladys is fictional, but she's based on 2 real-life patients, and I think there's some really important points here that I suppose just, that hopefully we can go away and think about what this would be like in our clinic setting. So she's aged 50, she's got hypertension and depression, and she was diagnosed with HIV at age 38. She's got a good CD4, she's undetectable viral load. She was on darunavir, ritonavir and Truvada, and it was simplified to Simtusa 4 years ago. She's on pretty normal co-medication as far as these conditions would lead you to link to. So ramipril, amlodipine, atorvastatin and fluoxetine. So atorvastatin's on the lowest dose because of the boosting effect of the ritonavir and the cobicistat. Amlodipine 2 is on the lower side of the dosing. So you'd be wanting to make sure that her comorbidities were well controlled. She hadn't actually been offered anything else for her depression. She hadn't been offered any non-pharmacological any talking therapy or CBT or anything else. She'd just been on fluoxetine and she didn't feel it worked that well. She's got a high BMI, she's married but has no children. She was a previous smoker, she drinks alcohol at the weekends and she tries to get to the gym when she can. So I think quite a typical patient. But let's fast forward 20 years. So people living with HIV now, the HIV, as I mentioned, is often the least of the considerations. So what do we need to think about? So when patients age, there's lots of age-associated changes in pharmacokinetics. So there can be changes in gastric pH, distribution, albumin, body fat, lean muscle and total body water, metabolism changes with changes in hepatic mass and blood flow, and elimination changes with regards to GFR and renal blood flow. So often we have to think about different or altered dosings in an ageing population. What about pharmacodynamics? So you can have increased effects with certain groups of drugs. So benzodiazepines, you can have increased sensitivity in the elderly. Opioids too, you would want to start with lower doses. Beta blockers and diuretics too, and anticholinergic agents, which I'll touch upon later. Really important that we do consider anticholinergic burden in people living with HIV, and not just our extreme elderly population. Gladys is now 70 and her HIV remains well controlled. Her CD4 is still good, she's still undetectable, and over the last 10 or 20 years she's had 3 blips associated with periods of depressive illness, but it's not resulted in any resistance, and she's now on Biktarvy. But her journey over the last 20 years as she's aged has meant that other comorbidities have popped up. So perhaps related to menopause, she's had an increase in migraines, she's put on a bit of weight, back pain, her hypertension and depression has remained, she's had a diagnosis of polyarthritis and back pain, osteoporosis, CKD stage 3, and at age 70 she still maintains episodes of depression and has had an AKI at stage 1, and this is now the medications that she's on. So she's on ramipril, amlodipine, atorvastatin, and I'll let you read through this list. So if I'm seeing her in an HIV clinic, what do I need to think about? So she's doing great, she's on 1 tablet once a day, I'm seeing her every 6 months, she's got an undetectable viral load, she's taking her medication for her HIV, but her general health is declining, and she's on all these other medications, and is this prescribing appropriate? So what's my role now here? Do I just give her 6 months of medications and send her on her way, happy that she's taken her Biktarvy and I'll see her again in 6 months' time? Or do I have a look and think there's some things jumping out there that are not appropriate? Do I speak to her about how her compliance is with her other medicines? How are her other comorbidities being controlled? Who looks after her? Who else does she go and see? Is this everything else in primary care? What other specialists does she attend? So first and foremost, with our HIV care, that's our bread and butter. Is our medication appropriate? Are there any drug interactions? Are there overlapping toxicities or side effects? So that would be, my first thought. And multimorbidity, I suppose the role of the Liverpool website is drug A plus B, but when there's lots of other drugs going on, it's about having that knowledge and understanding, of the effect of all of them in the body. So I think that comes back to the question I asked earlier, the polypharmacy review. Is it my job? Is it, if not, whose is it? So is it the HIV physician? Are we happy to say that somebody else is going to be dealing with that, or do we need to look at who that somebody else is? What about multimorbidity scoring tools? I think these are important that we use in the right context. We understand that they're there. So another plug for Liverpool, we started a multi-risk scoring tool on this website, so the Liverpool Multimorbidity Org, which has been developed with Lauren Walker, one of our kind of expert clinical pharmacologists and consultant medics, who's kind of put all the tools that we use in one place, so you don't have to enter data every different time to get all your different scores. You can enter it once for the specific patient information and get the results. So that's all in one place to help us guide how we look after our patients. So 70 years old, Gladys is now 70, so let's have a look at what she's on. So Ramipril and amlodipine, she's still hypertensive, but nobody's actually looked at the fact that she's not on a boosted drug anymore and she's still on those lower doses, and that's the same for the statin. So atorvastatin 10 milligrams is rubbish. You may as well not be on anything. So it needs to be higher than that if it's going to do it. If we think she still needs it, it needs to be higher. Historically, she's been on a boosted drug and she's been on low doses and nobody's titrated that up again. So she's now on escitalopram. Is it working? There's an increased risk in bleeding. How well is it managing her condition? Do we need to think about something else? And temazepam, 10 milligrams, she's on at night. There's a really high anticholinergic burden with that. I'll come to that in the next slide, but a score of 3 or above is considered a real high risk for frailty and death, and that's associated with 6 with just one drug. So does she need it? It can be really hard to tackle benzodiazepine prescribing, but is there other agents that might have a lower anticholinergic burden? She's been prescribed carbocisteine and nobody knew why. She had a bit of a cough about 10 or 12 years ago, and it's actually the wrong dose that she was on anyway, so that can be stopped because it's a load of rubbish. And lansoprazole, again, looking back, there was no clear indication of really why it was ever started, and she wasn't sure either. Things like her back pain, she'd been on alendronic acid for about 12 years. There's good data now that there's still risks associated with these agents, and there's data now that perhaps you could consider drug holidays with things like alendronic acid. I mean, that's part of a bigger discussion. OxyContin long-term use has its issues as well. She's on ferrous sulfate, which is of course really constipating, and you can see that she's on Movicol, which is possibly because of that or the effects of the OxyContin. But it's an osmotic laxative and possibly a stimulant might be better. She's on metformin. Is that the best thing for our diabetic control? Could you add something like linagliptin? 10 years later again, because we're well, and 80 is the new 50. Her HIV still is well controlled. I'm still just giving her 6 months Biktarvy and sending her on her way. However, lots have happened between the age of 70 or 80. She's had multiple hospital injuries. She's now got bladder instability. She's had falls, postural hypertension, pneumonia. She's had TIAs and she's had multiple hospital admissions, and she's now in a care home. and she's probably approaching end-of-life care. So again, what do we think about that? What's our thought processes for our medication? So when we're talking about frailty, this is not my slide, but I think it's important to highlight an 83-year-old can look very, very different. So with the same comorbidities, and it's understanding who might be at risk of frailty and what it means. So again, at age 80, does she need to be on all these medications? Is there anything that we can wean down? Because for preventative medicine, is symptoms control and managing toxicities something that her quality of life is more important without the kind of extra effects of all these medications? So can we look at stopping some agents, weaning down? And again, that's part of a big discussion. I'm not going to go through it all, but at 80, when you're perhaps looking towards end of life, there's certainly lots of medications there that could be stopped. I'm going to just one more minute. Accumulation of medicines, risk, anticholinergic burden. There's lots going on where there's an anticholinergic risk in some medications, and these were medications that she's been on over the last 10 or 20 years, where the anticholinergic score for this particular lady was really, really high and way above what it should be. Anticholinergic burden is associated with some medications that you might not think, so it's always worth looking at, and she has had that real 5 years of medical history of cognitive impairment, incontinence, falls that perhaps could be linked to her prescribing. So there's lots of tools out there for that. There's no gold standard. A score risk of greater than 3 has a higher risk of confusion, falls, delirium and death. And there's often nice and easy switches that can be thought of. So some drugs, perhaps like quetiapine with a score of 3 and with a switch to risperidone of a score of 1, or oxybutynin with a score of 3 could be switched to mirabegron with a score of 0. So again, just who in your team understands this, who in pharmacy, if it's pharmacy, can look at these things. And just finish off to say, when you have a patient in front of you on many different medications, let's have a look at what is used to treat symptoms and what is used to prevent disease. And at the age of 80, when we're looking at perhaps end of life or managing symptoms, then let's have a look at just a focus on how can we make this patient as comfortable as we can in their kind of final year, 5 years, 10 years, but do we need to look at perhaps large-scale disease prevention? And these were hospital admissions at the last 5 years. So just my last slide, so the future and the role of the pharmacist. I think we do have to have a look at managing multimorbidity, and whether it's not us, do we link in with primary care? Do we need to link in with primary care better? Do we need to link in with primary care pharmacists better? And how can we make sure people living with HIV do meet that kind of last 90 with regards to quality of life, and make sure that they're that 90-year-old at the kind of starting line in the race? And grateful thanks to everybody at the University of Liverpool, and particularly Lauren, who helped with the case, one of the patients with her own. Thank you very much.